Hi, I'm Dr. Yusuf Mohammed, and I'll be talking to you today about migraine headaches. I'm an associate professor of neurology at King Saud University. Migraine affects all kinds of people. It affected many important people in science or politics or literature, such as Julius Caesar, Thomas Jefferson, who was a United States president, Napoleon Bonaparte from France, Charles Darwin, the master of the hereditary theory, Leo Tolstoy, who is an important and prominent Russian writer, Alfred Nobel, who discovered the dynamite, and there is now the Nobel Prize in his name, Alexander Bell, who discovered the telephone. All of these people, they suffered, or they used to suffer from migraine headache. Sigmund Freud, who is the master of psychoanalysis, and George Bernard Shaw, who is an English writer. So all of these people used to suffer from migraine. So it was postulated in the past that migraine affects smart people, but the reality is it affected all socio-economical class of people, whether important people and regular people. My talk today will be divided into five sections. One is we'll start with the historical background, then we'll move to the epidemiology of migraine, then pathophysiology of migraine, followed by the acute treatment of migraine headache, and we conclude the lecture talking about how we can prevent migraine headaches. So let's start with the background. Headache and migraines affected human beings since probably creation. This photograph here showing you it's a statue from South America. It's around 4,000 or more years old, showing or demonstrating that it's a person suffering from headache, probably migraine headache, because it's at the bitemporal area. This is a picture, what we call skull trepanation, that used to treat all kinds of diseases, including migraine headaches. And this is around 3,000 years old. The trepanation, or perforating the skull, was used for many centuries, and this is showing you the actual tool to trepanate the headache or trepanate the skull, and you can see also the instruction at the top of the device or tool. This is the operating room. This is maybe 1,000 or year old, showing a patient his skull being trepanated. Whether it's for headache or not, this remains to be determined. However, this showing how the primitive ways of treating headache and other diseases. The first theory, or the first person that described migraine headache was Hippocrates, this was in 470, around 470 BC, and he described the migraine as shining light, usually in the right eye. This is probably here he's describing the migraine or visual migraine aura, followed by violent pain at the temples, at the temporal areas, and eventually it reached the entire head and the neck. So this was the first description of migraine headache. And this is showing you one of the wealthy patient suffering from headache and migraine, and he's being treated by honey and opium to relieve his headache. This is again a primitive way of treating these migraines. This is one of the military leaders used to suffer from migraine, and one of his soldiers, he stripped the head of a big fish, exposing the teeth and the bone, and he asked him to scrap his temples with the fish teeth and his headache was better. And this meta leader, he took this fishbone to France to give it to the king of France, who was suffering from migraine. It's not clear if the king at that time he used this to treat his migraines or not. This is a Dutch engraving from the 17th century. This is a migraine sufferer, and the way he was treating his headache was putting the glass globes at the temporal area, and after heating it, and once this gets cool, it will suck the blood from the temples, and the headache will be relieved. However, the first scientific theory for migraine was delayed until 1930 by Harold Wolff. His theory was, or he postulated the vascular theory for migraine headache. His theory stated that migraine starts with intracerebral vascular constriction. And because of this, they will have a decrease in the blood flow, and this will lead to an aura, which is a focal neurologic deficit. Now, the brain will react by dilating the vessels, and there is a nerve endings around the vessel. And when the vessel dilate, you will have increased blood flow, and you will have throbbing, pulsating, pounding headache. So this was the first scientific theory in 1930 by Harold Wolff. And he demonstrated that ergotamine, which constricts the blood vessels in the brain, relieves the migraine headache. So he used this as a proof that the migraines starts with vasoconstriction followed by dilatation, and this is when the patient will have pulsating headache. However, there is a limited use of ergotamine because of sometimes inadequate efficacy, and also we don't know what's the best dose for ergotamine. And more importantly is that of the significant and sometimes serious adverse reaction of ergotamine causing coronary arteries constriction. The next scientific theory for migraine mechanism was actually the neurovascular theory, and this theory states that migraine is not a pure vascular event. In fact, there is some kinds of neural events that starts, and the end results is the dilatation of blood vessel leading to throbbing, pulsating headache. So this is what we call the neurovascular theory. Also, it was found there is an indirect relationship between serotonin, which and migraine. And in 1996, Humphrey was able to clarify the first serotonin agonist, and he called it Sumatriptan. And Sumatriptan, which is a serotonin agonist, and this is to prove the neurovascular theory that actually migraine starts with some kind of neural pathway leading to the dilatation of the blood vessels. And Sumatriptan in 1990s was tried in a big or large randomized clinical trial, and shows it was effective in treating or aborting migraine attacks. We'll now switch gears and move to the migraine epidemiology. Migraine is very common. 18% of females suffers from migraines. 6% of males suffers from migraine. The total population affects 12%. So it affects 18% in females, and 6% in males, and 12% of the whole population. So it's a very prevalent disorder. And the highest prevalence is in between the 30 and 50 years of age, and this is the age when the population are at their highest productivity. If you compare migraine prevalence to other chronic diseases, it only drags only behind hypertension, which is around 26%, and migraine around 12%. The prevalence of migraine is higher than diabetes, which is 8%. It's higher than asthma. It only drags behind hypertension in terms of prevalence. The majority of migraine sufferers, their headaches is severe to extremely severe. 90% of migraineurs, their headache is severe to extremely severe in intensity. There's also the other associated symptoms are common. For example, those that are suffering from migraine, 81% they will have photophobia, 77% will have phonophobia, 74% they will have nausea, and 30% they will have vomiting. The majority of the patient, 75% of migraine sufferers, they will have less than 3 attacks a month. 14% will have more than 5 attacks a month, and 11% will have 4 to 5 attacks a month. Around 50% of the patients or migraine patients, their headache will last around 24 hours. The migraine sufferers, the impact is enormous in their life. For example, 75%, when they have an attack, they will be unable to do any housework hold. 67%, their productivity in terms of household work, 67%, their productivity will be reduced more than 50%. 59% will miss any family or social activity during an attack, and 51%, their school or work productivity will be reduced by more than 50%. The bad news also, that only 48% are diagnosed by a physician. So what I mean by this is a patient, they have migraine headache, and only around 48% they will be diagnosed by a physician. So what I mean by this is that 50% will be undiagnosed, and only 23% will receive medication for migraine. What I mean by this is migraine-specific medications. The majority, 49%, will receive analgesics, over-the-counter analgesics, and 5% will be not using any medication. In terms of economical burden, for example, in the United States, it costs the country around $14 billion to take care of migraine patients every year. The majority of this, which is $13 billion, will go to indirect cost because of missed works, missed schools, and reduced productivity during these attacks. Only $1 billion will go to direct medical costs like inpatient and physician visits and prescriptions. Now, we'll move to the migraine pathophysiology. As I mentioned, the first scientific theory was the vascular theory by Harold Wolff, which states that migraine starts with vascular constriction. Because of this, there is decreased blood flow and an aura, which is usually a visual aura. The brain reacts because of decreased blood flow from vasoconstriction by dilating the blood vessels, and this is when the patient will have the pounding, throbbing headache. And I mentioned also in the previous slides, he showed that ergotamine, which acts by constricting the cerebrovascular system, relieve an attack. So he used this as a proof for his vascular theory. However, what are the drawbacks against the vascular theory? Number one, some of the drugs used to treat migraine do not act or has no effects on the blood vessels. Number two, most patients has no aura. And number three, the evidence from many studies do not support the theory. In other words, there are inconsistent evidence in favor of the vascular theory. The next theory, as mentioned in the previous slides, is the neurovascular theory, and this states that migraine is not caused by only a primary vascular event. In fact, it's a disorder in which neural events precedes the development of headache. So, based on this, or based on the concept that serotonin was found to relieve a migraine attack, the Humphrey and his colleagues clarified in 1990s the 5H receptor responsible for selective cranial vasoconstriction and also blocking the pain pathway. That led to this led to the development of the Sumatriptan, which is a serotonin agonist, and this based on the neurovascular theory that there is a neural events precedes the vascular events, which is the dilatation of the blood vessels. So based on this neurovascular theory and based on the fact that serotonin can relieve migraine headache, they discovered the Sumatriptan, which is a selective serotonin agonist, which does two things. One, it constricts the blood vessel. Number two, it blocks the brain pathway, leading to relief of migraine headache. So Sumatriptan, which is a serotonin agonist, was tried in a randomized trial, a large randomized trial, and it showed efficacy in aborting migraine attack. Around 65% of acute migraines were relieved by the Sumatriptan when compared to placebo. And this was the Sumatriptan was followed by around 5 or 6 other serotonin agonists. We call all of them Triptans, and I will mention their names in the next slides. And all of these Triptans have the same mechanism of action, which is serotonin agonist. All of them, they promote vasoconstriction and they block pain pathways at the brain stem level. The last theory or hypothesis is for migraine mechanism is the cortical spreading depression. And this was based on Lashley, who used to suffer from migraine and migraine aura. And this is a actual diagram for his aura. It's a scotoma. It's a black spots, which starts at 0 with small black spots. In 3 minutes, this spot will enlarge. In 7 minutes, it becomes larger, and in 10 minutes, it becomes even larger. And again, he was reading the newspaper, and this is his actual visual aura. There was at 1 minute, there's a small black spot that it gets larger at 5 minutes and larger even larger at 15 minutes. Then this was correlated with an EEG or electroencephalogram, and they found that this visual aura on the left correlates with electroencephalogramic wave changes that will expand within few minutes. And this was the basis for the cortical spreading depression. In other words, the cortical spreading depression describes that the aura begins with neuronal hyperexcitability, and this when the patient will have a zigzag light, bright light, sparkly light, followed because of this hyperexcitability. This is followed by depression of this neuronal activity, and this will spread to other neurons, leading to neuronal dysfunction and the visual aura. Now, most clinicians or scientists at the current or at the present time believe in the neuronal dysfunction, which is this spreading or cortical spreading depression in the mechanism of migraine aura. Now we'll move to the fourth section of my talk, which is acute migraine treatment, how we can abort migraine attacks. What is the evidence? Well, before I do this, first we have to agree that the patient is suffering from migraine headache. In other words, not every headache is a migraine headache. Not every headache that is throbbing and pounding is a migraine headache. Not every headache that is associated with nausea and vomiting is a migraine headache. So the best thing is to go and abide by the International Headache Society criteria for diagnosing migraine headache. And this criteria states the following. A, at least 5 previous attacks for following B and D. B is said that headache attacks should last between 4 to 72 hours. C, the headache attacks has 2 or more of the following characteristics, and this is C. 1, unilateral location. 2, pulsating quality. 3, moderate or severe pain intensity. 4, it's aggravated by any physical activity. So 2 of these 4 characteristics, unilateral or pulsating or moderate to severe intensity or aggravated by physical activity. D, any of the headache attacks should be associated with one of the following: nausea and or vomiting, or photophobia and phonophobia. So one of these two characteristics. In terms of migraine with aura, so the first was migraine without aura. How about the criteria for migraine with aura? It says that A, at least 2 attacks fulfilling criteria B and D. B is 1 or more than 1 attack should have reversible aura symptom. Usually it's visual, but you can have other symptoms like sensory, language, motor, or even brainstem like vertigo or dysphagia or dysarthria. And C, 2 or more of the following characteristics. The one aura should spread gradually over more than 5 minutes, or 2 symptoms occur in succession. 2, each individual aura symptom should last between 5 and 60 minutes. 3, 1 aura should be unilateral. And 4, aura should be accompanied or followed by headache in less than 60 minutes. So all of us should use the International Headache Society criteria to diagnose migraine without aura and migraine with aura. Now, how about the treatment? First, sometimes you have to treat the associated symptoms. Many of the migraines, around I think 70% or more, they also suffer from nausea and vomiting, and you have to treat these sometimes devastating or disabling symptoms. The nausea and vomiting, and the treatment option for this is the metoclopramide or the prochlorperazine. Now, how about the actual headache? How you treat it? And the best thing is to use the US Headache Consortium guidelines, and it says that for mild to moderate attacks, you can use simple non-steroidal anti-inflammatory agents or simple analgesic for mild to moderate attack, and this per the recommendation of the US Headache Consortium. Now, for moderate to severe attack, the US Headache Consortium guidelines recommends the serotonin receptor agonist, which are the Triptans, the Sumatriptan, and the others. For moderate to severe attacks, and this has a grade A recommendation. And I mentioned all of these triptans, the serotonin agonist for moderate to severe attacks, they share the same mechanism of action, which is promoting vasoconstriction and blocking the pain pathway at the brainstem level. Now, these are the present or available triptans in 2016. The first one was the Sumatriptan or Imitrex. Then we have the Zolmitriptan or Zomig, Naratriptan or Emerge, Razatriptan or Maxalt, Elitriptan or Relpax, Elmotriptan or Axert, and the last one is the Frovatriptan or Frova. Now, they all have also they share the same efficacy. In other words, based on a study comparing Relpax or the Elitriptan to Sumatriptan, the 100 milligram was almost as efficacious as the Elitriptan. In other words, around 55 to 60% efficacy in aborting a migraine attack. And also based on the meta-analysis that was conducted by Ferrari. In this meta-analysis, they want to show, in this meta-analysis, they want to try to determine which triptan or which serotonin agonist is more effective than the other. And based on these meta-analysis studies, they were almost all similar in aborting attack. For example, the success rate in being pain-free at 2 hours was around 16 to 20%. Whether with the Sumatriptan, Zomig, and the others. Again, this slide showing the efficacy of all the triptans. They were almost equivalent in relieving a migraine attack. Also, some of the agents were less successful in terms of the headache or in terms of the return of the headache after a few hours, especially with the Maxalt and the Zomig. They have the highest rate of return of headache at a few hours. But in terms of relieving or being pain-free at 2 hours, they were almost all the same. Now, again, in terms of the efficacy of other agents, the DHE and ergotamine also is effective for severe or moderate migraine headaches. And this is the grade B and C, comparing it to grade A with the triptans. The opioid, they have grade A and B in relieving moderate to severe attacks. However, you have to be cautious in using the opioids and the narcotics because of the risk for sedation and dependency. Now, also, the antiemetic that was mentioned previously, like the metoclopramide or the prochlorperazine, they are effective not only for nausea, and also they're effective in relieving migraine attack, and this is a grade B recommendation. Other agents like the isomethaptine is useful for mild to moderate pain, and this is grade B recommendation. Now we would switch gears to the last section of my talk, which is migraine prevention. Well, now always whenever you want to start, whenever you are encountering a migraine patient, I will always start with the migraine hygiene. I always tell my patients, first, you have to avoid triggers for your migraine. So I tell the patient you have to watch for any triggers in your, some patient, some kinds of food, like salami or coffee or cheese, they can trigger an attack. So I tell them to watch what triggers the attack and try to avoid triggers. Some patients like red wine, they can trigger an attack, or preserved meat, they can trigger an attack. So they have to avoid these triggers. They have to have regular meals, because many patients, when they have irregular meal, they will have an attack. They must have also regular sleep, because some patients, some migraine patients, if they have irregular sleep, this will trigger an attack. They have to avoid as much as possible over-the-counter medication, because if these patients take the analgesic frequently, they can develop what we call analgesic rebound effect. So I tell them to try to avoid as much as possible over-the-counter medications. They have to exercise. Education is very important. The more the patient learn and know about their disorder, the better is the outcome. So we must always educate our patients about the migraine headaches. As also relaxation technique and biofeedback. This is what we call migraine hygiene. Now, there is something called also preemptive prevention treatment. Preemptive. In other words, if a patient suffers from, if he exercise triggers an attack, so I tell them to take like a non-steroidal anti-inflammatory medication like indomethacin, like 1 or 2 hours before they exercise. Or patient with menstrual migraine, that they have migraine headache during their menstrual cycle. So sometimes we give them non-steroidal before the menstrual cycle, and then continue through the whole menstrual cycle, or we give them one of the serotonin agonists, the Sumatriptan, was found also effective in preventing menstrual migraines. How about long-term prevention? Now, when do we decide to prevent migraine attacks? If patient has frequent attacks, more than 4 migraine attacks a month, then this is one of the indication for starting them on preventive medication. If the patient have a prolonged attacks, if they have only 2 attacks a month and each attack lasts more than 3 days, then this is an indication to start preventive medication. If they have very disabling migraine attack, this is another indication. If there is any of the acute migraine medication treatment, like Triptans, if there is any contraindication for the use of Triptans to abort an attack, then this is an indication to use preventive medications. If there is a basilar migraine, and because of the risk that basilar migraine will lead to a stroke, then this is an indication to use preventive medications. There's 2 kinds of preventive medication. One is pharmacological treatment, and the other is non-pharmacological treatment. And per the US Headache Consortium guidelines, the non-pharmacological modalities may be provided before or in conjunction with the anti-migraine pharmacological prophylaxis. And the non-pharmacological intervention includes the behavioral treatment and the physical treatment. Now, The behavioral treatment, which has grade A and B recommendation, include the relaxation training, biofeedback therapy, the cognitive behavioral therapy, and the stress management treatment or training. How about now the pharmacological preventive treatment? And this includes around 5 classes of medication. One is the beta-adrenergic blocker. 2 is the antidepressant, the tricyclic antidepressant medication. 3, calcium channel blocker. 4, serotonin antagonist. And 5, anti-epileptic. Now, how do we choose one of these? What determines the choice of one of these agents? One, this based on the side effects profile of each one of these medication, and more importantly, a coexistent comorbidity in this patient. For example, if patient has problems sleeping and has migraine, then the best agent is the anti-tricyclic medication because it causes sleepiness at night. If a patient is overweight and has migraine, then the best prophylactic medication is topiramate or Topamax because it causes also weight loss. If patient has migraine and epilepsy, then the best agent will be again anti-epileptic like Topamax or Depakine. Now, we always, when you start a preventive medication, always start at the smallest dose, and then you can escalate your dose until you reach the maximum dose, or if there is an adverse reaction from the medication, then this is when you should stop and switch to another medication. So in other words, you don't start at the smallest dose, and a patient, and if this is shown to be ineffective, then you stop the medication. No, you should escalate and increase the dose until you reach the maximum dose before you say that the patient the medication failed to prevent the migraine attacks. Also, a full trial may take around 2 to 6 months for every preventive medication before you say that this medication is ineffective in preventing migraine attacks. Now, also, every few months, you should try to gradually decrease and taper this medication to see if there is any, if the patient has no more headaches. In other words, because migraine headache usually improve with time, so you should every few months try to taper this medication off and determine if there is a recurrence of the headache or not. If there is a recurrence of the migraine attack, then you can resume this preventive medication. Also, a woman of childbearing age, you should always make sure to use adequate contraception before you start the migraine medication, because all of these medications, they carry a risk of fetal malformation. So that's why you make sure that the patient is in the appropriate and proper contraceptive method. Now, the drugs that has shown high efficacy in preventing migraine attacks, at the same time they have only mild to moderate adverse reaction, include the topiramate or Topamax, beta blockers, amitriptyline, and Depakine. The second group are the drugs with lower documented efficacy, but they have mild to moderate adverse reaction, include the SSRIs, calcium channel blocker, gabapentin, and riboflavin. The drugs used based on opinion only include many of the antidepressants like doxepin, sertraline, and trazodone. Now, I will end my talk by displaying the American Headache Society and the American Academy of Neurology Society Migraine Prevention Guideline. And this is what is their recommendation. Level A recommendation, which means established as effective regimen for preventing migraines. Level A, and this is based upon the American Headache Society and the American Academy of Neurology Society recommendation. This level A includes Depakine or the valproex, topiramate, propranolol, metoprolol, timolol, and petacides. This is level A recommendation based on these two societies. Now, level B which means probably effective for preventing migraine. The first one was level A, which is an established efficacy. Level B means probably effective. And this includes the amitriptyline, phenoprofen, feverfew, naproxen, magnesium, and riboflavin. The last slide is level C, recommendation, which means possibly effective. And this include candesartan, clonidine, carbamazepine, cyproheptadine, guanfacine, and pendolol. So this are the recommendation of the American Headache Society and the American Academy of Neurology recommendations. Okay, you have level A, level B, and level C. I think this is the last slide. Thank you for your attention. Thank you.